Just sorting just a couple of minor glitches. But let me just start by saying that thanks very much to all of you who are joining here today in the room and also online. We're not necessarily having a tally of how many people register for each seminar, but this is a very impressive interest raised. So it's a pleasure for me to introduce this seminar and our speaker. Our speaker is Professor Evangelos Kontopantelis, Professor of Data Science and Health Services Research at the University of Manchester. He holds degrees in computational statistics and machine learning and has a long track record in research using large-scale primary care and administrative databases to investigate quality of care. His methodological interests include statistical methods in health sciences with a focus on meta-analysis, longitudinal data modeling, observational studies with electronic health records, spatial epidemiology, machine learning, and quasi-experimental designs. Prof. Evan is a visiting professor with us at the Department of Family Medicine. I read it all to ensure I wasn't leaving too much out, but I could probably have already said plenty of it just from memory because it's I've had the pleasure of working with Evan over the last, well, not 20 years yet, but close to in different collaborations and capacities. So I'm really excited about this seminar, which is also a collaboration between the Division of Family Medicine and the Department of Family Medicine, and also CRiHSP, the Centre for Research in Health Systems Performance. And well, without further ado, I'll be very happy to hand over to you.
Thank you. Thank you for inviting me again. I will be talking about the Quality and Outcomes Framework, which was implemented in the UK around 2004. Okay, that's good. So a little bit about the people involved in this work. It's lots of work in that space. It was a very expensive program and did a lot of evaluations to convince or not the government to proceed with it or not. Some information about the program. What we did in terms of investigating aspects of the program. A summary. So, like I said, lots of people, some retired, we look much younger there, Tim as well. A lot of money went into the program, and of course, a lot of research funding went into the program as well to see what it was actually achieving. And I cannot claim most of the work I will be presenting because I was a small group in most of the analysis, most of the research projects. Martin Rowland was the head of the department when I joined Munster in 2005. So he's a very senior, semi-retired academic GP. Rumor has it that the QOF was designed on his coffee table at some point. Tim Doran, who's now in York, I worked with him very closely when I first moved to Munster. David, who was my mentor in Munster, has now retired. Stephen Campbell is still in Munster, so he led the seminal study on the QOF. Bonnie Siebold as well, heavily involved, retired now. Matt's still in Munster. Matt Sutton, health economist. Hugh Gravel, I think, health economist in York, retired now. Gemma here, and many others, too many to mention. So the scheme, why is that in italics? So me being Greek, I only realized that later. So in British English, you will say operation scheme, or you say based on performance link. It means a plan. Now in American English, I think it has more sinister connotations. So when we're presenting some of the work, and GPs or academics weren't happy with paying GPs, they were saying, of course you're calling it a scheme, like it's an evil plan to give money to GPs for doing nothing. what is the heart of the plan? So the underlying aim was to improve quality of care. And obviously it came with a very juicy carrot. So it was introduced in April 2004. And basically general practice or family practices were rewarded for achieving a set of quality targets for patients with chronic conditions. And a large number of conditions as well. So it was a very broad. What was the aim? To, on paper or anecdotally, to increase overall quality of care and to reduce variation in quality between practices, which was seen back then. And it was named the Quality and Outcomes Framework. Now, the estimate for initial investment was around 2 billion, 1 billion for 3 years. So it was set out to increase the income of GPs by around 25%. And the idea was for it to be reviewed every 2 years, and it was. I mean, now we're obviously over 20 years has been active. So some details just to give you an idea. So what happened in year 1 and in year 7, when after which year it had expanded quite a lot. So originally it was 10 conditions, it went up to 19, close to 80 indicators for clinical care. Most of our focus was on clinical care, but there were other aspects as well. Organization of care, additional services, patient experience. It was implemented simultaneously in all practices. Now, from a policy point of view, that's absolutely fine, not from a research point of view. So obviously we didn't have a control group, and that's quite common in policy. Because the policymakers are not that keen on us conducting proper research. They want things to happen magically. So an important provision I will come to later is exception reporting. So obviously, GPs were paid to conduct certain measurements, certain interventions on patients, hit certain targets and be rewarded. So if I check the blood pressure measurement of 80% of the population have, in terms of having had a stroke in the past, yeah, I will get paid. Obviously, the provision, the exception report provision was there to protect patients so they're not penalized by GPs for not complying. You're not coming in for me to measure your blood pressure, so I'm not happy, so I will exclude you from the practice, for example. Something like extreme like that. So obviously, it's an important provision, but then the counter argument was, well, are GPs getting paid to exclude patients? So again, that's something we wanted to look into. It's well into the 21st year now. It has changed dramatically over time. So now it's much smaller to what it used to be, and it has completely been abolished in Scotland. And I'll come to this later. And the cost for the first 10 years was way above the initial estimate. So for the first 10 years were about 10 billion. I said the estimate was 1.8 for 3. So what does it mean in practice? So if you have one of these conditions, for example, atrial fibrillation, asthma, like I said, it ended up being a list of 22 conditions, but also covers learning disability, obesity, if you want to call it a condition. Now it's more common, back then it wasn't. Palliative care, sexual health, smoking. For example, for diabetes, what would GPs be looking at for diabetes? Well, the standard things, basically. So measuring and controlling blood pressure, cholesterol, glucose, immunization for influenza, some physical exams that relate to complications, right? Retinal screening, food exams, and many others. It's one of the largest domains. It was one of the largest domains with 17 indicators. Yeah. And obviously, considering the size of the population of diabetes, one of the most rewarding financially domains. Yeah, next slide. So what was the reaction in 2005? So this is not, let's say, the best newspaper in the UK, and more to follow. But this was the initial reaction from the yellow press. So doctors get paid to do their jobs. So GPs paid to compile lists of obese patients, even though it does nothing. Yeah. So obviously the GPs were paid to create the list, but it was a small incentive, which was increasing with every intervention or every other measurement they did. So GPs made 162 million out of ghost patients hanging over the building. So obviously, in in England and the UK, you have the option to move GPs frequently. And back then, because computerization was not ideal, when people were moving, GPs either weren't quick enough to strike people off the registers. So there is the abnormality that if you add up the patients registered in UK primary care, you get a population that's larger than the population of the UK. And still, this has been rectified to some extent, but it's still ongoing. And there was an argument that GPs weren't particularly quick to delete patients from the register. Can unfortunately, that's more to the point, without any more information. Can GPs do their job properly? I don't remember the context of what this relates to, but this is representative of some of the reaction. I mean, it's very common for the yellow press in the UK to try to pit one group of people against another group of people, and here patients basically against GPs, and it's quite common. Bonuses for doctors, how GPs are earning up to £380,000, which is an extreme outlier. It was an extreme outlier back then, and £200 an hour for work they used to do for free. So needless to say, it wasn't received very positively. And these are some of the questions we had. And like I said, there's a lot of work in this space. I'm focused on the work we conduct as a group. And there's much more work conducted by other groups. But we were back then the National Primary Care Research Centre of the UK. So most of that work was coming to us through Martin Rowland. What were the levels of achievement when the QOF introduced? Was there any point to it? If achievement was very high, what was the point of introducing it? Did that change over time if it was lower? But what was happening before it was introduced? Was there an increasing trend? So who have achieved those targets eventually? Who performs well? Does size matter when it comes to practices? Because there has been a large trend towards larger practices in the UK. Are the deprived areas, practices in deprived areas performing as well as practices in affluent areas? What does exceptional reporting do? Is it a valid tool for protecting patients, or is there gaming with practices using it to get more money and not treat patients? That's all fine, maybe everything is going fine. What happened to aspects of care that were not incentivized? Does that mean that care on those domains deteriorated because there wasn't that much attention paid to them? Did we see more benefits for certain population groups compared to others? How did that affect patient satisfaction? And there's many more questions. So that's a timeline to give you an idea of the first 10 years, basically, of the studies that were running at the time. And I'll tell you when I arrived. So there was a study called QUIP with a small sample of practice that started running in '98. And obviously, it was sort of, because Martin Rowland was involved in it, he actually set that study before the introduction of the QOF. So we had a perfect cohort of a small number of practices, yeah? And we had measured information in previous time points, so we would actually evaluate what was happening before and what happened after with the interactive time series analysis. But obviously there's more data. That's when the QOF introduced, and we started having national data from this point onwards. From this point, we had access to CPRD data, which is a large database of electronic health records, so we could conduct different types of studies. We had access to a newly released back then patient satisfaction survey, et cetera, et cetera. And this took us quite a few years into the QOF. That's up to 9 years, where most of the work was conducted. That's when I arrived in the UK, but that's not me. Right. So you'll notice a trend, because it was new and popular. This is a New England Journal of Medicine paper. It gets much worse. So we start on a high, but then as the interest deteriorates, you'll see we end up with much lower impact factor publication. So what did we report here? It's the first year of the QOF, so brand new, very expensive program. Everybody's interested. What does it do? So achievement was very high in the first year, yeah, 83.4%. Most of the indicators had a ceiling of around 80%, yeah, even without accounting for exception reporting, 80 to 90%. There was a small effect of socio-demographic characteristics. Exceptional reporting was used, but it wasn't the strongest predictor of outcomes. And very few practices scored high by excluding many patients, but you wouldn't call it extensive care. Now, that was a normal practice, obviously, but it was the first year they obviously thought they would give it a try. Now, this is a follow-up. The second study we conducted was used that representative sample of 42 practices that I mentioned were recruited before the introduction of the course. So that study focused only on 3 domains: coronary heart disease, asthma, and diabetes. And we saw that there was some improvement. This is when the QOF was introduced. Yeah, so there were 3 time points in that study. And there was an improvement post-QOF. Yeah, but there wasn't any increasing trend in performance in the years before. That's what the study aimed to see. What was happening before? So the increase in rate of improvement was significant only for asthma and diabetes. As you can see, for coronary heart disease, is pretty flat. Yeah. So what happened before? Maybe practice were preparing in anticipation of the launch of the QOF. So this puts into context the whole intervention and makes us think maybe the gains from the scheme are questionable, in the sense that pre-intervention trends show that there was improvement beforehand. Perfect. So another study we conducted, we wanted to see, now we're 3 years into the QOF, and we want to see what's happening over time. So there was an improvement in the first 3 years from 85 to 89, 91%, and median achievement increased for the most affluent and the most deprived practices. Here you can see the graph. Red is the most affluent, blue the most deprived, and you can see how this improves over time, and they're almost identical by the 3rd year. So obviously, this shows evidence of reducing inequalities. So it's doing what it's supposed to be doing. Now, in that study of 42 practices, we had another time point in 2007. Now, this is the same as before, from 98 till 2005. But see what's happening between 2005 and 2007. Very little improvement. So by 2007, the rate of improvement had slowed down for all 3 conditions. What other aspects did we measure? We measured continuity of care, which deteriorated a little bit. Yeah, because it wasn't the priority. It wasn't the priority seeing the same GP. And there are other parameters that contributed to that. I'll come to that later. There's no significant changes on access to care, so getting an appointment basically, or getting through to the practice on the phone, or interpersonal aspects of care. So what was the key message from that? Well, probably QOF accelerated short-term improvements. So you can see we're already on an increasing trajectory. QOF took us there very quickly, and then the trend plateaued sort of again. So if you extrapolate these lines, practically it would be around here. So is it worth the cost? Another question we wanted to answer is the practice size. So in the UK, there was something I'm not sure you remember or have come across. There was a shipment case. There was a single-handed GP who murdered lots of elderly patients, basically. So following that, there was a big, obviously, concern. And one of the things the government and the Royal College general practitioners thought as a good way forward was to move away from single-hand practices. Yeah. So there has been a big driver of many years towards massive practices. So practices that now have 20 or 30,000 patients. Yeah. Similar to the polyclinics you have here, but a single-handed GP would have a practice of around 2,000, 3,000 people, and most of Europe is still organized like that, as far as I know. Yeah. So the UK is a bit unique in that. But that trend didn't make disappointed many GPs who were used, especially older, who were used to working in single practice. And they were pushed to merge, basically, because of the QOF as well, because it's a big administrative burden. It needs to be done once, whether you have a single-head GP who can't afford to have an administrator, who need to do it themselves, or whether you have a practice with 10 or 15 GPs. It's the same return. So inadvertently, QOF drove primary care in the UK towards larger practices because of the added administrative burden. Because 25% of your salary depended on those returns. So what did we see? So we saw that performance improved over time, and the smallest practices, this is the smallest practices, improved at a faster rate. Yeah. So they start slightly smaller, lower performance, but then they are on par with the larger practices, even though there's more variability. So again, we see that QOF reduced variability between large and small practices. Now, what happened with patient experience? And we'll go back to that sample of 42 representative practices we followed for over a decade. So there were no changes between 2003 and 2007 for quality of care, communication, nursing. Now, aspects of access improved for chronic disease patients only. Now, that's important because the QOF focused on chronic conditions. So the question is there too much focus on that population and not enough attention paid to other aspects of care? But both, so that's a sample of patients with chronic illness and randomly selected patients, basically. And both those samples, though, reported that they were seeing the usual GP less and less. And they were less satisfied with the continuity as well, which is expected because if you have a merging, if primary care is merging towards larger practices, you're much less likely to see the same GP. It's common sense. Now, there was another incentive that contributed to that was seeing people quickly. So practices were incentivized to see somebody within 24, 48 hours. Obviously, if you have an emergency and your regular GP is on holiday, you'll see somebody else. Yeah. So that affects continuity of care. Now, about patient satisfaction, how potentially the QOF and how has that, what's the association with patient satisfaction? How did that change? So obviously there's an ethnic element to it in terms of an age element to it. So young, they have different expectations possibly. Asian, working full time with low commuting times, lower level of satisfaction and experience of access. But all of that usually was taken away when you had the opportunity to take off work to visit your GP. Now, the interesting thing here, which went against the grain, is that patients in small practices were much more positive for all aspects of access, except opening hours. Yeah. Again, that's not completely surprising because, say, in terms of access, getting through to the phone, it was at a time when maybe technology wasn't great or merging large practices didn't have that many administrators to deal with demand. But nevertheless, it was something that went against the grain of the trajectory in the UK in terms of super practices. And there was an association of positive access. So practices that have positive access scores had higher QOF scores. So if they're good, they were good across the board. There was a piece of work we did as well. So because of all that, NICE, which is the body that advises on funding in the UK, came to us to do a piece of work because up until then, we didn't know what would happen if indicators are removed. Yeah, and economists, health economists, argued that that was the way forward. So if you remove an indicator and introduce another indicator, then you'll see gains in the new indicator, and people are used to doing the activities that are associated with the old indicator, so we'll keep doing that anyway. So you win-win the cost is the same, basically. So we suggested some ways to deal with that. And nobody knew what happened if we withdraw indicators, because that was all, like I said, the program was pretty new. But nothing happened there, because it's a big political exercise as well, and all the bodies are pushing for their own interests. So even though we made some suggestions, they ended up being published in the BMJ, nothing came out of it. Now, another piece of work we did was look, using now the CPRD data, so we could get access to aspects of care that weren't incentivized, because up until now, either with the national data, either with that sample of 42 practices, we only had information on incentivized aspects of care that were part of the QOF. So using that sample, we were able to construct indicators that were both incentivized and were not incentivized. Now, the big challenge was finding evidence-based indicators that were not incentivized, because the QOF was so large, it included almost everything under the sun for those chronic conditions. Yeah, and even for those indicators that were included in the QOF, the evidence sometimes is sketchy. Yeah. So, for example, measuring somebody's blood pressure. What does that do exactly? What is the evidence that this keeps somebody out of hospital? It's very difficult to say. Now, if you control somebody's HbA1c levels, fair enough, there is clear evidence for that. But we're talking about measurement indicators, talking about treatment indicators, and intermediate outcome indicators. Many of the indicators that we have are a review. You sit down, I discuss something with you. What is the evidence for the impact of that? So what we saw is significant initial gains in incentivized indicators, which likely agree with what we were seeing with the national data. Yeah. And there was no overall improvement for not incentivized indicators. Yeah. So the non-incentivized indicators are here. Yeah. So continues on an increasing trend, but you don't see the jump that was driven by QOF. Now, another piece of work we did was focusing on exception reporting. Like I said before, it's a very interesting provision that can be seen in two different lights, as positive and as protecting patients, and as negative in terms of gaming on the part of the practices. So the median exception rate was very low, like 2.7%. Yeah. And it was even lower for informed dissent. So the patient saying, I don't want this done to me. I don't want you to measure my blood pressure. Now, the most common reasons were logistical. So somebody registering with the practice just before the return of the QOF, things like that, moving practice, which are common sense. Yeah, so clinical contraindication, again, common sense. And like I said, patient from dissent. But these are relatively, like I said, very low. It's 2.7%. And the high rates were associated with larger practices, probably people knowing how to play the game better. Higher deprivation, which again is probably educational, people refusing treatments. But also failure to secure maximum remuneration in previous years. So if you were bitten the previous year, you didn't get the maximum amount of money, then you were more careful to use the provision the following year. But if you think of the cost of the provision at not even £1 per patient, 31 million, how much did I say it was per year? 1 billion per year. This is a drop in a bucket, basically, for a very important provision to protect patients. Yeah, so even if a few practices game this systematically, it's worth the money. And we also saw that incentivized activities were broadly acceptable to patients, very low informed dissent, which is positive as well. Now, there was another, there was a change in one of the indicators. So it's a very interesting experiment that practically was parachuted on us because we didn't have any control. We didn't understand why the change was made. But it was made. So there were 4 influenza immunization indicators for 4 different conditions: for CHD, COPD, diabetes, and stroke. Now, all these indicators have an upper threshold above which you're not paying. say, if you meet your target for 90% of your patients, then you get the maximum points, you get the maximum money. It doesn't matter if you treat 90%, 95%, or 98%. Yeah. So 1 year, the upper threshold increased by 5% only for CHD. Why? Don't ask me, I don't know. But like I said, many of these drivers are political. Yeah. So that gave us a nice natural experiment to see what the role of that 5% increase was in one of the indicators. So what happened? So led to an increase in the percentage of immunized CHD patients by not 0.41%. So did what it's supposed to be doing, but also increased exception reporting. It's like I said, it's not unusual, especially if you're close to the ceiling, because the effort to get 8 out of 10 patients to immunize themselves is not the same. It's arguably the same as getting the last 2 patients to accept the intervention. Yeah. So as you get close to the ceiling, obviously exception reporting will be used more because you're dealing with the most difficult patients to bring into the practice, the most difficult patients to accept the intervention, et cetera, et cetera. So what was the finding, the overall finding? Making quality targets more demanding can lead to quality improvement, but it can have unintended consequences as well. And you can see how skewed the distributions are, for example, over time for that particular indicator. So driving improvements from this point onwards can be pretty hard. So it sounds surprising that we had that increase in exception reporting. It's relatively large compared to the additional number of patients immunized. In another piece of work, we focused on diabetes. Like I said, diabetes is the largest domain in terms of indicators, the largest in terms of the prevalence, the population in the register, that has the condition. And I have a personal interest in diabetes and cardiovascular disease as well. So we wanted to see what happens specifically for diabetes. And you can see the trend, you can see where we are each year, and that uses CPRD data, so electronic health records data, that gives us the advantage of being able to look at the characteristics of the patients. With the national data, all we get is the numerator and denominator. We don't have the characteristics of the patients. But we could see here if improvements were across the board for males, females, by age group, by certain socioeconomic status, et cetera, et cetera. So there was variation by sex, age, years of previous care, and number of comorbid conditions. All these played a role. Interestingly, how many years you've had the condition made it the biggest difference. And you can see for new diagnosis, now part of it might be logistical. You don't have the time to measure somebody's HbA1c level, so you defer them to the following year. But we did sensitivity analysis, and it seemed that because GPs could exception report them logistically, they didn't bother to actually do the activities in that year. So they were deferring them to the following year, which, maybe the risk was small because they were newly diagnosed, but it's very difficult to say. The market, the landscape in terms of clinical computer systems in the UK is interesting. Here, as far as I understand, in this hub, South-West, you all have the same system in polyclinics. So it was much more like the Wild West in the UK for many years. So many of the systems were developed by very IT-savvy GPs in the 90s. In 2007, there were 7 clinical systems. 5 years before that, there were 20. Now we have 3, for example. You can see the trend. So obviously the market is now being dominated, but back then we had 7 clinical computer systems. And the market share was different in different regions of England because they were driven by the specific consortia of GPs that had developed them or were very affectionate towards them, and they didn't want to change. And what we saw is that system choice was the strongest predictor of performance on the 62 indicators that were stable from 2007-8 to 2010-11, which was a surprise to us. So was it that particular system characteristics facilitate higher quality of care? Is it a case of better recording, better prompts? All that is very likely. Obviously, there is regional variability as well that you need to account when it comes to that. But we did try to control for that. So finally, one of the lowest scoring systems is now the key one in the UK, even though it has changed. You know, it's in its fourth or fifth iteration now. But maybe not necessarily the best systems when it comes to recording survived. Now, up until this point, indicators have never been withdrawn. Like I said, there was mixed feelings when the program was introduced. A lot of money went in it, and there were concerns that it was good value for money, as with any aspect of funding and public health. So for certain indicators, incentives were removed. Yeah, they were trying to cut down the cost of the program and prioritize some of the indicators. So indicators within asthma, CHD, diabetes, stroke, and psychosis domains, some of the incentives were removed. Two were removed in 2006. Again, it has to do with evidence as well behind each indicator. And the levels remained stable until 2012. Now, for 5 of the 6 indicators that were withdrawn in 2011, there was no change within a year. So within the study, we didn't have such a long follow-up, but again, that we had no idea what we would see. So the finding from this was, you know, for these 2 indicators, didn't make a difference. 5 out of 6, no change. So short term, at least, withdrawing the incentives doesn't lead to a rapid deterioration, which is good to know, which again fits back into what I said about us advising NICE, that actually recycling indicators might be the way forward. Some of the other work we did was focusing on health services research and people with severe mental illness. What happened? Did the QOF have an effect? Had any role in how people were experiencing interaction with primary care or family medicine. What we saw is that for people with SMI and a control group of similar age and sex characteristics, face-to-face consultations were stable for people who didn't have SMI, but was a great increase for people with SMI who were already visiting GPs quite often. So obviously the finding from this was actually QOF worked well in that sense, that incentivized GPs to improve monitoring of people with severe mental illness. One of the key things that we said about the QOF is there was so many potential gains thrown around the implementation of the program. One of it might have been, it's debatable, whether it prevented premature mortality. So the hard outcomes, what's the hard outcomes that we have in research in this space? Death and hospitalization. Yeah. So if it stops either of these, then it does a very good job. Yeah, it's unlikely, but it's worth having a look. So, so we looked at all cause and cause-specific mortality rates, yeah, and they all declined over that study period, 2007, 2012, and the austerity in the UK and the financial crisis hadn't really hit us hard by then. And higher mortality was associated with greater air deprivation, well known, urban relocation, well known, higher non-white population, well known. There was absolutely no relationship between practice QOF performance, sorry, that's a typo, and mortality rates in the practice locality. Yeah, that was published in the BMJ. By then, Martin Rowland had moved to Cambridge, and he wasn't happy with that paper at all. Because obviously we have to make certain assumptions, it's an observational study. And you can see some of the maps here, the nice graphic. So this is Greater Manchester. This is spatial maps of what we call lower super output area. It's an average of 1,500 people, 1,600. And here you see mortality. Yeah. This is the center, obviously, and you can see this is younger people generally. This is very, very deprived areas here and here, Oldham and Wigan. And this is performance. As you can see, probably performance is higher where mortality is higher. Anyway, it's a mixed bag. There's no clear pattern. After that, I received an invite from a colleague in the States who was interested in a different method to approach the problem. So it's called a synthetic control method, which health economists use when they have the data. And the best way to do it is at the country level. So what he did was create a synthetic England from other 27 other high-income countries. So you weigh them appropriately and you create a synthetic England. And then you calculate age, sex, adjusted mortality per 100,000 people for all the composite of chronic disorders targeted by QOF and some other specifics like ischemic heart disease, cancer, and then a composite of all target conditions. And QOF was not associated with significant changes in any outcome. Yeah. Now, I mentioned hospitalizations as well. There is some evidence, and we want to look into it as well. There was evidence from another group. So what we consider as hospitalizations from ambulatory care sensitive conditions, they're considered preventable, or treatable, say asthma, diabetes, epilepsy. The idea is that if they're managed well in primary care or in the community, people won't end up in hospital. So they are considered sensitive in actually seeing if primary care has actually preventative effect. Now, it had an effect, but it was very small. That makes you think, is it worth the money? So it was a very small effect of the QOF on reducing admissions. So a 1% increase on QOF achievement, and you need to think how skewed the distribution was. Yeah, so from 80 to 81%, you probably take you to a large jump in the distribution. At the whole country level, so if all practices went from performance of 80 to 81%, we will deal with a 0.07 reduction, which is around 800 hospitalizations. And other factors such as deprivation and urban location were much more important. We're coming to the end of the journey. So Scotland, they like to do their own thing. Yeah, so it's an independent country, sort of. So the systems are very different. Getting data from Scotland is very different. And they decided they didn't want the QOF anymore, and they withdrew in 2016. Much earlier than, I mean, it has been downsized in the rest of the UK, but not completely removed. So again, that created a nice natural experiment where we compare the performance in Scotland to England. So there was a decrease in most indicators. So when everything was stripped out, basically, in 12 out of 16 quality indicators after 1 year, there was a reduction, and 10 out of 16 after 3 years. So there was a big drop. And that has affected recording as well, because it's not just managing those patients, it's the wealth of the data we're getting from these incentives. Then we know that the data are accurate, that we can use for research as well, but it's very difficult to put a price on. So, to summarize, so we had very high levels of initial achievement. Practices were expecting it, they were ready for it, and that led to overpayment. There's still confusion about what was the aim. Is it the aim to reward high quality of care or to drive improvement? You can have both, but then you have very different starting points of the people around the table to discuss how the incentives would work and would be tweaked. It appears that the same levels of care would have been met eventually. QOF arguably took us there 2 or 3 or 4 years more quickly. It reduced inequalities, but it negatively affected continuity of aspects of non-incentivized care. It helped the trend towards bigger, better organized practices, but that wasn't always liked by the patients. Exceptional reporting is a cheap provision that ensures patients are not discriminated. Yeah. And we saw the small changes in the details can have big effects on quality of care. Just increasing 5% the target can have serious implications. There was variation in the intervention effect across patient groups, certainly for diabetes. And we saw the clinical system was unexpectedly a very strong predictor of performance, something that I wouldn't have guessed beforehand. So withdrawal of indicators with the scheme active led to no drop in reported quality in the short term. It affected consultation rates for some chronic conditions, like SMI, for example. There was no effect on mortality. Very small effect on what is considered preventable hospital admissions. And when we had a complete withdrawal in Scotland, we saw a quick deterioration in most recorded quality of care compared to England. Thank you.
Thank you. Thank you. So we have another 12 minutes or so for questions. Any questions here from people in the room? Yes.
When you say those patients under the exception group, does it mean that no indicators were performed for them?
So what do you mean?
So there is nobody took their blood pressure, they declined to vaccinations and so on?
Yeah, for a specific indicator, not for everything. So you might have somebody, so people with diabetes says, oh, it's time for your food examination. I don't want a food examination, but you can measure my blood pressure. So it was indicator specific, not across the board. Now you might have the same patient who refuses more than one aspect.
And so for those who were in the exception group, did their health deteriorate compared to those who had a full suite of?
So we didn't look at that with, you can do that with individual data because we were looking at the national data where it's at practice level. Yeah, so we couldn't link that to specific patients. You could do that with the CPD data, for example. Yeah, but recording of exceptions there wasn't as good, so we didn't consider doing it. And it's a very difficult study because you will have absolutely worse outcomes for the population, especially if they're more deprived, if they refuse all interventions. So we didn't think it was worth pursuing to some extent because we knew the answer. There's a question there. How long did it take to show the very small?
Do you mind reading the question? Sorry.
I'm reading the question, trying to understand how long did it take to show the very small reduction? These were annual hospitalization rates linked to a practice, if that's what you're asking. So it's the number of hospitalization prevented within a year. So
I guess that the question is whether that was detectable very soon into the program, or whether there was a lag.
So we tried a few models and we're already in the program. We didn't look at it from the beginning. So it was 5 or 6 years into the program. And we tried different lag models, but it was consistent. So it's very difficult to answer how long because the program was already ongoing. And if you had very high performance the previous year, it's very likely you have high performance the following year.
Yeah.
So can't really answer that with certainty. Following the withdrawal of QOF in Scotland, did performance on the indicators regress to the long-term pre-incentive trend line or above below? That's a good question. I actually don't remember. I would be very surprised if it was below. From what I remember, and remember, we hardly have any data before 2004. We only had that for a sample of practices. It's above 2004 levels, I think, but because we had such quick gains within a couple of years, it's probably to those levels. But it will be interesting to see what happens in the short and medium term if we get even below that. What possibly led to the smaller? So the performance was better in larger clinics. What was worse in smaller clinics, in larger clinics, was satisfaction with access and continuity of care, which is expected. So patients valued more access and seeing the same GP, arguably, over having all the boxes ticked in terms of their chronic condition.
And can I ask, like amid all these studies in the program, are there data points you wish you had? Did you run into data capture issues? Are there more information about the patient or about?
Absolutely. I mean, the biggest barrier for us was that most of the data was at the practice level. So we couldn't follow our patients specifically. So some of that was done using the CRiHSP data, which it was much more complex and onerous as well to try to recreate all the indicators as well that you had manually. Like even the withdrawal of indicators, we wanted, for example, the data to continue to be collected when the indicators were withdrawn. It didn't happen. It happened in Scotland. They did it in the area in Scotland. Let me see. I think that was national data. Again, there is a cost attached to doing that. So there are many things that could have been done differently, including, for example, a control group, having a control group from the beginning or trialing it for a few years would have made a lot of sense.
Let me help with the question from David. So basically, we have Healthier Singapore, which is a new initiative here, trying to boost primary care. And David is drawing a comparison here, thinking, okay, so can we, based on the experience of evaluating the impact of a program, in this case QOF, what we should be paying particular attention if we're trying to evaluate this national program here at practice or national level going forward?
So I guess it sounds very similar. The question would be having the data to answer the question, because the questions I think you want to answer is it acceptable to patients? Is it acceptable to clinicians? Does it improve quality of recorded care? Are there inequalities introduced in any potential increases, or are existing inequalities decreasing across people at different socioeconomic strata? And in an ideal world, does it lead to fewer hospital admissions? Extend people's lives? So I guess you have the same questions. It's whether the data is there and the availability and the design, so you can answer those questions robustly.
I would like to, I'm aware that we have only 5 more minutes, but there was a question here whether you were missing more data or either data points or richness of the data. What I would perhaps also would be interested in knowing is what were the additional methodological challenges, and that not necessarily in terms of the data availability, but in terms of for modeling, obviously there is a lack of control in many instances. Anything that you found, that you think that after the whole process you're now in a better position to address, but that were significant challenges in the process.
Yeah, so I didn't know much about was experimental designs when I started, and now I'm considered I think an expert in interrupted time series analysis for my sins. But you do the best you can with the data you have. In the absence of a control
Yes.
group, everything is a nightmare.
Yes.
Because you have different methods with different assumptions. Now, my pet hate is people saying this is causal, but there's always a set of assumptions that come with it. Whether you assume X or Y or Z, or you assume there's no exogenous factors, or you have an instrumental variable, that's a different approach, or you have synthetic control country or whatever. So the idea is to try to minimize the bias. Yeah. What's the bias here? The bias here that mainly is the pre-intervention trend. So you have already had improvements. You need to account for the pre-intervention trend. If you have, say, a point here and a point here, you can do a t-test, yeah, and you see if there's difference. Fine, there's difference, there's improvement. But you didn't account for the pre-intervention trend that if you account, there's absolutely no difference. And that's the challenge usually with these designs. And having a long enough follow-up and a long enough pre-intervention trend that's linear to be able to use this method is the biggest complexity. Because again, these are the assumptions. It's not always linear, don't have enough time points, and it's very difficult to know where to draw the line and say that's not a good enough analysis.
And if I also make a comment, because I think that many people will be very keen to draw comparisons, say, okay, so the learning points, no? But I think it's also important to know that because as noted, the systems are very different. So the impact is also mediated by many other variables in the system, and that has to do with how care is financed, how care is accessed, and what are the how hospital care is, because the primary care doesn't work in a vacuum. So when you look into issues like admissions, primary care has a role, but then there is a reserved services that has to decide whether they admit or don't. Or similar with mortality, it may be very good at may do the job, primary care, at allowing need to emerge, but then somebody else also needs to be able to pick it up. And so some of the effects or lack thereof in the UK may not readily apply to what we could see here in Singapore. Would you agree?
Yeah, absolutely. I mean, it's two different things. I think you're implying exogenous factors as well. So the idea is if everything else is similar or the pace of change is not that great, and luckily for us, it wasn't. I mean, if you told me now to redo the analysis and include time points from 2015-16, where the NHS is massive and has massively deteriorated in those time periods with waiting lists. But if you say, right, I'm looking at 2004 to 2010, waiting lists are the same, take the same time to be seen, admissions are the same, deaths are the same. We don't have any major. I mean, we had a sharp increase in deaths in younger people after the economic crisis, for example, which have skewed the results. So all these things, and when you are in a point of crisis where other things in the system break down, it's very difficult to point to that thing and say, well, that's it, because you have all that. So if everything else is relatively stable, that method works. Now, again, that's a good point, because I said for a very long pre-intervention period, a very long post-intervention period, the longer the intervention period as well, the more likely is that it will have an exogenous factor. So you need the happy medium as well, because if you look over 20 years, medicine and care will have changed dramatically as well across all aspects. So you need to be wary about intervention. And I mean, the NHS is a bit of a monolith, as you know, so not much change. So it was maybe the perfect setting for that to be measured with hardly anything else changing. While here, if you have lots of things happening at the same time, it would be very difficult.
Thank you, Evan. And on that,
Is that,
happy, I think they are, well, basically, we're looking to implement growth from scratch. As I'm aware, we have exceeded the allocated time, and we may be able to answer some more information informally. I would like to thank all the people participating remotely in the seminar, and also here, and Evan for the fantastic presentation. So please join me again in thanking Evan for this seminar. Thank you. Thank you.